So thank you for coming today. So my name is Russ Judd. I'm a clinical pharmacy specialist at St. Joseph Hospital in Lexington, Kentucky. And we'll just go ahead and jump right into it. So in February of 2017, the World Health Organization developed a list of priority pathogens that pose the greatest threats to public health. And at the top of that list were carbapenem-resistant organisms, which they deemed as critical threats to society. So around the same time, or several months later, they also published a report describing antibacterial agents in various stages of clinical development. And the authors concluded that the current state of the clinical pipeline is really insufficient to mitigate this growing threat of antibacterial resistance. And this was a headline on one of CNN's website at the time, which said the world is running out of antibiotics. And so in addition, the authors also stated that antibiotic development should go hand in hand with other infection prevention and control activities, as well as fostering of the appropriate use of both existing and future antibiotics through stewardship measures. And so that's really going to be the focus of today's presentation. And starting a couple years ago, we really decided to take a more holistic approach to our patient care and antimicrobial stewardship activities, starting from the time of presentation in the emergency department at the top with our adult code sepsis policy, progressing to our rapid molecular diagnostics program. Again, talking today about how we have really incorporated the BCID panel and other rapid diagnostics into our daily stewardship practices. Next, our clinical triggers program, which required automatic ID consultation for patients with high-risk medical conditions or other multi-drug resistant organisms. And then finally, to prevent any horizontal transmission of resistant organisms between patients, we've also focused on other isolation precautions in our terminal cleaning process. So you can see, again, starting at the very time of presentation in the emergency department all the way through the time of discharge when we're focusing on terminal cleaning. So starting in July of 2017, we implemented our ED Adult Code Sepsis policy. And when we talk about sepsis, in general, you can see a progression from over on the left-hand side of the screen, what we term as SIRS, or Systemic Inflammatory Response Syndrome, through septic shock. And as we move from left to right on this screen, the risk for in-hospital mortality in general increases. So with Systemic Inflammatory Response Syndrome, or SIRS, those generally include patients who present with multiple SIRS criteria, including a temperature above 101 or less than 96.8, an elevated heart rate above 90, respiratory rate above 20, and a white blood cell count of greater than 12 or less than 4. So at that point, though, we don't say that the patient has sepsis in the absence of an infection. So if they have multiple SIRS criteria present, in addition to a suspected or documented source of infection, at that point we call them septic. And then in the third column, we can see severe sepsis would include those patients with sepsis, plus at least one sign of acute organ dysfunction. So all of the criteria that you see listed here are all signs of tissue hypoperfusion in patients who present to us with severe infections. In the far right would be patients with septic shock. So after we identify patients with sepsis, we initiate early sepsis treatment bundles, including IV fluid resuscitation. And in those patients who have persistent hypotension despite fluids, we call those septic shock. So again, in July of last year, we implemented our ED Adult Code Sepsis policy to really in an effort to quickly identify and to treat patients who present with both sepsis and septic shock. And so now, for every patient who presents to our emergency department, the ED triage nurse will screen them for the presence of 2 or more SIRS criteria, and with or without hypertension, so systolic blood pressure less than 90. For patients who do have multiple criteria present, the triage nurse will then immediately escalate that case to the attending physician who's on service at that time to determine or to further evaluate the patient for other suspected sources of infection. At that point, if they suspect an infection and they have multiple SIRS criteria, any member of that team can activate our Code Sepsis Alert, and this works very similar to what you might see with a Code Blue or Rapid Response or Code Stroke at some of your hospitals. We have a standard set of labs that we would order for those patients, including a comprehensive metabolic panel or CMP, CBC with autodifferential, 2 sets of blood cultures, and what we refer to as a lactic acid level with reflex if indicated. And then at that point, when the team responds to bedside, we could then initiate all of the 3- and 6-hour bundle elements that are required for early resuscitation of that patient. So many of you have probably seen some of these studies showing the impact of delayed antimicrobial therapy in patients with severe or complicated infections, including septic shock. And on the left-hand side of the screen, you can see the impact of delayed antibiotic therapy from the time of hypotension onset. So if you look at the first hour from hypotension onset, you can see that overall survival is approximately 80%. But for every hour delay in initiation of antibiotics, there's about a 7.6% decrease in survival. So if you can think we send antibiotics to the floor or to the emergency department and they sit around for a couple of hours, that really increases their risk for mortality. On the right-hand side, you can show a similar effect with delayed antifungal therapy in patients with invasive fungal infections, starting on culture day 0, which was the time that cultures were obtained, when mortality is around 15%. If therapy is delayed until day 1, that increases to approximately 24%, and then 37% and 41% by day 3 and beyond. So starting in January of 2015, that's when we implemented the film array multiplex PCR system at our facility. And there are currently 4 panels that are available for syndromic testing, including respiratory, blood culture ID, gastrointestinal, and then the meningitis encephalitis panel, which was just described. So the respiratory panel, the first one was available at our hospital. It's primarily used to detect viral pathogens. We're now combining those results with other clinical biomarkers of infection like procalcitonin levels to assist with antibiotic de-escalation. The blood culture ID panel has really been the cornerstone of our program at St. Joe, and I'm going to describe that in more detail on the following slides. The gastrointestinal panel and meningitis encephalitis panels are also used at our facility, but to a lesser extent. And then finally, the pneumonia panel is still investigational use only, but will include additional targets for some antibiotic-resistant genes, including CTXM, ESBLs, KPCs, metallobeta-lactamases like NDMs, VIMs, IMPs, and then other targets for methicillin resistance. So the blood culture ID panel is capable of detecting up to 24 pathogens. There are 19 gram-positive and negative bacteria, as well as 5 Candida species. These are all detected in 1 hour from performing the test. And in addition to those, there are also 3 antibiotic-resistant gene targets, including MEK-A for methicillin resistance, VAN-A-or-D for vanco resistance in Enterococcus species infections, and then finally the KPC carbapenemase enzyme. So shortly after implementing the film array multiplex system at our facility, we also developed a rapid molecular diagnostics protocol. And so according to this policy, all positive blood cultures are initially identified using our BacT-Alert system and assessed via gram stain. Any positive cultures, as long as they are not gram-positive bacilli, will then immediately reflex to our multiplex PCR system for faster identification. In addition to that, routine microbiologic testing is performed in order to determine final culture and susceptibility results, and those are also really needed to further de-escalate or to streamline antibiotics. And then finally, testing is performed on the first positive blood culture unless subsequent bottles show a differing gram stain and/or morphology. So in addition to educating the microbiology staff, we also provided extensive medical staff education in order to accurately interpret the results and to initiate appropriate therapy. And so because final culture and susceptibility results are not available at the time that PCR testing is performed, all of these empiric regimens were designed based on antibiogram data from the preceding calendar year. So what you see on the screen would give the provider the highest likelihood of success based on susceptibility results from the previous calendar year. And all of these, of course, would be tailored to your local institution. So additionally, a growing body of evidence also suggested that mandatory infectious disease consultation resulted in greater adherence to evidence-based treatment guidelines, as well as reduced in-hospital mortality and earlier discharge. And our clinical triggers program was developed really in an effort to improve both clinical and economic outcomes in patients with both multi-drug resistant or high-risk medical conditions. And so according to this policy, ID consultation is required when any of the 5 high-risk medical conditions shown on the screen are isolated in the microbiology lab or they are strongly suspected by the provider. And those would include bacteremia, candidemia, cardiovascular device-related infections, CNS infections like bacterial meningitis, as well as infective endocarditis. And so once a clinical trigger is identified, the microbiology lab will immediately notify the ASP team, as well as infection control personnel and other environmental services employees to identify and to treat that patient. So in addition to that, the micro lab would also contact the nurse who would communicate those results with the hospitalist or the primary care provider taking care of that patient. If we receive the notification during normal hours of operation, the ASP pharmacist is responsible for contacting the ID office directly to initiate the consult and to communicate results and other important criteria with that physician. And then the order for ID consultation is routed to the provider or primary care physician for co-signature. So in addition to the high-risk medical conditions, ID consultation is also required for any of the multi-drug resistant pathogens shown on the screen, including CRE, ESBL positive isolates, multi-drug resistant Acinetobacter and Pseudomonas, and then finally vancomycin resistant Enterococcus species. And the process in terms of notifying the ASP team or other infection control personnel is the same as what I described on the previous slide. And then finally, I mentioned that our holistic approach looks at time of presentation to time of discharge. And so we also implemented our patient care cleaning program to ensure that rooms were adequately cleaned for those that were occupied by patients with MDRO infections. And so we use a sodium hypochlorite or bleach solution to clean high-touch surfaces throughout each room. For certain organisms like CRE or MDR, Pseudomonas, and Acinetobacter, we also use a double terminal clean process where rooms are cleaned twice, separated by approximately 4 hours. In addition to that, we also, in order to ensure that the bacterial loads are eliminated from room surfaces, we use a device that measures bacterial ATP on high-touch surfaces throughout the rooms. And so you can see some of the areas that are identified throughout the room that would be considered high-touch surfaces. Okay, so in order to wrap all of those things together, I also wanted just to present a case to show you sort of the timeline from time of presentation to discharge. So JR is a 63-year-old white male who presented to the emergency department with acute hypoxic respiratory failure, hypotension, acute kidney injury, confusion and somnolence, as well as worsening left knee pain and swelling. Patient received a steroid injection 3 days prior to admission for treatment of left knee pain. And the patient was subsequently brought to the emergency department when his family noticed increased confusion. So you can see on the right-hand side, this would be the vitals that were present as close to the time of triage as possible. So you can see that the heart rate and respiratory rate were both elevated at 104 and 30, respectively. The systolic blood pressure, in this case, was reported as 81 over a diastolic of 44, and the mean arterial pressure was 56. So this patient presents to us already with multiple service criteria present, as well as at least one sign of acute organ dysfunction being hypotension at time of presentation. So once the ED triage nurse noticed that multiple service criteria were present, again, she would escalate that to the attending physician who was on service at the time. He determined that there was a suspected source of infection, including the synovial space or knee pain. And so he would order the standard set of labs for that patient. And those would include, again, 2 sets of blood cultures, as well as CMP, CBC with autodifferential, and a lactic acid level with reflex if indicated. At that point, because sepsis was deemed to be present, they would activate the code sepsis alert, and the other team members would respond to bedside and initiate all of the appropriate 3 and 6 hour bundle elements, including appropriate testing, which in this case, along with the blood cultures, we would order a synovial fluid culture to rule out infection in that area. The pharmacist would also then be present to assist with antibiotic selection, including ceftriaxone and vancomycin in this case, which was appropriate for the suspected source. And then IV fluid resuscitation was initiated for this patient with hypotension present at the time of triage. So once labs come back, you can see that the creatinine was elevated at 4, with a lactate also above 4 millimoles per liter, both indicating signs of hypoperfusion to vital organs. White blood cell count was elevated at 22.3. Platelet count was just over 100,000. And so if we combine all of these criteria and we look at what we call the CMS criteria for septic shock, you can see all of these combined would be used to define or be used as a case definition of septic shock. So these are some of the preliminary culture results that return, and you just notice that this was 14 hours and 26 minutes from the time of culture collection, and culture collection occurred almost at the time of triage. So we're talking about 14 to 15 hours from the time that they showed up at the hospital. The microbiology lab had identified gram-positive cocci in clusters in multiple bottles. At that point, because it was a positive culture and was not gram-positive bacilli, the lab would immediately reflex that to our PCR testing device, our BCID panel, and then within 1 hour we know what the organism is. So in this case, again, we identified gram-positive cocci in clusters, and we see that just over 1 hour from time of identification, the results came back from PCR showing Staph aureus detected. And then at the bottom, this is just how they appear in our CPOE system. You can see that methicillin resistance was not detected. So we would define this as MSSA, high-grade MSSA bacteremia in 4 of 4 bottles. Again, all of this occurred within 16 hours of presentation to the hospital, which is pretty remarkable. So once the clinical trigger was identified, being MSSA, again, the microbiology lab would contact our ASP team directly, and then we would follow up with the provider and adjust antibiotics if necessary. Because we were notified during those normal hours of operation, we would then also contact the ID office to initiate consultation with their service, and then communicate any culture or pertinent culture or laboratory results with their team so that we could rapidly de-escalate antibiotics. At this point, once ID had a chance to fully evaluate the patient, this was now 19 hours and 33 minutes from the time of culture collection, we were able to immediately de-escalate from that broad-spectrum regimen of ceftriaxone and vancomycin down to a first-generation cephalosporin, so one of the more narrow-spectrum cephalosporin agents. And this is all occurring within 1 day. So now I mentioned, I use the title of the case of the faulty system because we did have some interesting results with this. So with the first microscan report, it actually resulted as MRSA, but this was 66 hours after the time of collection. So already we have made appropriate antibiotic adjustments, but then these initial results come back as MRSA. It is our own policy that anytime we see discordant results between our automated system and PCR that we do repeat testing. And in fact, we did, in this case, in our repeat microscan report, did identify MSSA instead of MRSA to confirm the original PCR. Synovial fluid cultures also returned with MSSA, and so in all cases we were able to confirm that that was in fact the correct identification of the pathogen. And we've seen approximately 10 to 15 cases of discordant results between PCR and microscan. In approximately 100%, almost all cases, they have confirmed the original PCR results. And so that's why for us it's been especially helpful. So then we wanted to look at the impact of BCID testing and automatic consultation in patients with bacteremia. And so we conducted a retrospective observational cohort study. This was a single facility at our hospital. This was a 433-bed tertiary care medical center. Our goals were to determine the clinical and economic impact of both BCID testing as well as automatic ID consultation. So we included patients at or above 18 years of age with microbiological evidence of any bacteremia, including either Staph aureus or other gram-negative organisms. Positive blood cultures had to be obtained within 48 hours of presentation so that we could exclude those with hospital-acquired conditions. And then in our post-policy cohort, those would include those patients who underwent BCID testing as well as automatic ID consultation. So these are the results of our gram-negative bacteremia cohort. You can see in this middle column here the pre-policy cohort versus the post-policy cohort after both policies were implemented. In this case, there was a numerical reduction in the rate of all-cause mortality, although that difference was certainly not statistically significant. What we did observe, though, was a 2-day reduction in both overall as well as ICU length of stay. And that may not sound like a lot, but financially, so we'll talk about it in a couple of minutes, that can have a significant impact on hospital expenditures. Next, time from blood culture collection to speciation was reduced from 65 hours, so just under 3 days, down to less than 1 day at 18 hours. And then time to initiation of effective antimicrobial therapy was also affected. For the next cohort, Staph aureus bacteremia, you can see again the same 2 pre- and post-policy groups listed. In this case, our primary outcome of interest was all-cause in-hospital mortality, and we saw a reduction of approximately or nearing 20% from 27.3 to 8.1. Interestingly, we did notice that there was an increase in the total hospital cost per case. And so when we went to investigate the reason for this, we found kind of becomes intuitive after you look at the data. So based on our risk-adjusted numbers, the system felt that these patients who were at high risk for mortality were supposed to be in the hospital for only 1 day, because they were supposed to die on hospital day 1. And in fact, when they survived, they would be in the hospital for 10 days or longer, which costs money. So it does cost money to keep patients alive. In this case, though, we saw a significant reduction in overall in-hospital mortality, and you should consider that when you're developing your business plans or proposals. So, and then finally, I just wanted to briefly mention how to develop a business plan. And so, if you are working on antimicrobial stewardship programs at your facilities, I would highly encourage you read this article by 2 former division chiefs and a chief medical officer. And it was entitled, How to Pitch an Antibiotic Stewardship Program to the Hospital C-Suite. So on the left-hand side, you can see this is sort of a more idealistic approach where you have, let's say, an ID physician who says an ASP team is needed to combat the growing threat of resistance. Overall length of stay could be reduced by approximately 2 days. And then we have the chief medical officer who says, great, what are the projected savings and opportunities for increased revenue based on the current payer mix, case mix index, supply costs, and other operational expenses? And so if you're not prepared for that conversation, that's why it's extremely important to work with your finance team to work on some of these variables. And I'll just quickly go through this. First, you have to first understand the payer mix within your hospital. And by payer mix, I'm referring to the fraction of payment or reimbursement that you receive from any of these insurers, including Medicare, Medicaid, or private insurance companies. Medicare typically follows a bundled payment approach, where for individual payments, they will give you a base pay rate, and that's multiplied by the relative weight of all of the diagnosis-related group or DRG codes for that patient. So for example, let's say the base pay rate is $10,000, and we multiply that by a factor of 1.4. Total individual payment for that person would be $14,000. Medicaid follows either a fee-for-service model, where they will provide a flat daily rate, or a DRG model. And then finally, private insurers will use a contracted daily rate with possible patient-denied days. And then finally, I won't go into the details of this calculation, but these are sort of outlined in that article that I referenced. And you can see that with a 2-day length of stay reduction, if we assume that we can impact approximately 400 patients per year, that would be an additional 800 potential bed days per year that could then be filled with new patients and generate additional revenue. And if you think about how much money or revenue is generated from an empty bed, the answer, of course, is none. So we then have to fill that bed with new patients. And when you take into account the distribution or the fraction of reimbursement that's received from any of these insurers, you can calculate total additional revenue that's generated. In this case, it's approximately $1.3 million for the hospital. And then finally, for additional ASP benefits, you also have to consider additional variable cost reduction like antibiotics, lab tests, or other supply costs like IV tubing or catheters, etc. Fewer antibiotic-related adverse events and hospital-acquired infections, especially Clostridium difficile. Avoidance of financial penalties, and then finally patients and societal benefits. So although an increase in quality-adjusted life years and workforce participation may not be necessarily relevant to your hospital administration, ultimately it is still important for society. And that's it. Thank you.